Good afternoon. Welcome to Grand Rounds today. Today it's my pleasure to actually reintroduce Dr. Melanie Wellington. Dr. Wellington is a pediatric infectious disease specialist and also epidemiologist. She is a clinical associate professor of pediatric infectious disease and associate hospital epidemiologist at the University of Iowa. Approximately 18 months ago, she gave us a great Grand Rounds, and she has very kindly accepted our invitation to return virtually today to update us on COVID in kids. And please join me in welcoming Dr. Melanie Wellington.
Well, thank you very much. Zoom talks are always a little bit tough. So at any point, if things aren't going well, if we need to refocus or go someplace else, please just send me a message through the chat. I apparently can't see the question screen, but I can see the chat screen. So if you need to get in touch with me, go ahead and give me feedback through the chat as needed. So thank you all very much for joining me for this. Hopefully we'll be able to address some of the current issues. And again, if there's specific topics we want to get to, we can certainly go a different direction. So I titled this talk, Mind the Knowledge Gap, based off sort of a loose take from the London Underground. And the gap that is the sort of famous Mind the Gap is where the train and the platform don't meet up. Sometimes that's because the train and the platform have to curve, but there are other problems that can happen with the gap too, which is that sometimes you can step from the platform to the train, but sometimes you might step out to nothing, or even worse, you might step out when there's a train going on. And I kind of feel like that's a little bit of what we're doing right now, is we don't have enough data. So we never know when we step out where we're going to land. And we have to kind of keep an eye on this gap so that we know when we're doing things, do we know which way we're going? And so I'll get started with that. And I just should say that there is one therapy, I guess, that's approved for use in adults, which is remdesivir. Everything else that's a specific antiviral or vaccine therapy in this talk is under emergency use authorization or not yet approved. So unlike my normal talks in which everything is approved, pretty much this time nothing is approved. And I guess that's sort of the first step of that knowledge gap. This is where we'll go a little bit today. We're going to talk a little bit about the virus and a few things just as an introduction. And then we'll talk about some of the other current aspects, I think. This is a nice cartoon representation of the molecules of the virus. And you can see this is the spike protein, and it binds to the ACE2 receptor on the surface. That's certainly a topic of a lot of the issues around the virus. I'm told that this is the first mention of the virus from the Wuhan Municipal Health Commission. I don't read this language, so I apologize if that's not correct. But what I'm told it says is that the South China seafood market in our city has seen patients with pneumonia of unknown cause one after another. And that was December 31st, 2019. I don't have to do too much of this history because I know that you've all lived through it. But I will point out that it was on January 10th, 11 days later, when investigators sequenced SARS-CoV-2, which wasn't even named that yet, from patient samples. So we went from a description of the clinical syndrome to sequencing and identification of the viral cause in 11 days. And that by far sets land speed records for any type of infectious disease we've dealt with before in the past. And this is a theme for this outbreak, right, is that our abilities, our basic science abilities and our clinical science abilities have come so far, so fast recently that sometimes we're just sort of simultaneously ahead of ourselves and way behind, and you never know where to go. But that's how it started. And I do sometimes compare this to other epidemics that we've dealt with in the past. This is a graphic representation of epidemics. These fur balls are different epidemics that humankind has faced. Here's the Black Plague back here, the sort of black-purple fur ball. And here's the 1918 Spanish flu outbreak. And here in the dashed line is COVID. And you'll see this is from December 31st. Obviously, the number of deaths that have occurred from COVID has increased already, and it's ongoing. So that's why they've given this a dashed line. And the last time I sort of pulled this figure, it was a long time ago, and it was in March. And you can see that the ball was a very different size then. So obviously, this is this notation of ongoing nature of the pandemic is very real. There are actually some similarities to the 1918 flu pandemic, just to sort of bring out some of what we're facing. About a third of the global population was eventually infected with the 1918 flu, causing a tremendous number of deaths. All of these are estimates, of course, because we didn't actually have diagnostic testing. There was a significant contribution of global travel. This was one of the World War I was one of the first times that we had massive global travel, and it's no secret that part of the reason that this became a pandemic rather than a local flu epidemic or endemic area was because of this travel. And certainly today, our travel is orders of magnitude more, and things spread much, much faster. There were a lot of political controversies about the virus. It had a tremendous impact on the economy, which at the time was the war effort. And there was a lot of debate about how much impact we should allow and what else we should do. And there were politicians who would go out and make blanket statements denying public health risks or emphasizing fear mongering of excess public health risks. And there were a lot of data gaps. And believe it or not, this is true, mask mandates were issued, removed too early, and ignored. So there was always this controversy about how to prevent infection. And there was a major debate about whether or not to close schools. The big difference between flu and COVID was that schools are a hotbed of transmission for flu and not so much for COVID. We'll get to that later. I find it entertaining. Well, entertaining is not the right word. I find it academically interesting. Nothing about this is entertaining. But academically interesting that for flu, the U.S. Surgeon General prescribes salts of quinine. And if you look at quinine, this is the molecular structure. If you unwrap this crazy bit on the top for quinine, you get chloroquine. Neither of them work for flu, and chloroquine doesn't work for COVID either. But people were reaching for anything that they could. But I will point out that it was 15 years after the outbreak that we discovered human influenza virus. So there were some obviously major differences, and what had to be done was far more local, and there was far less really that could be done at the time. And but both of them caused massive mortality. And people like to point out all the time that COVID is not just flu. And when they mean that, I think they mean seasonal influenza, not pandemic influenza, of course. But since this is a talk about COVID in children, I feel like I need to point this out, that in some ways for kids, COVID is actually easier than the flu. So this is a graph of the infection fatality rate. So of those people who are infected, what percent are ultimately die from the infection? It's on a log scale, I want to point out. So this isn't, it looks linear, but it's not. It's very exponential. And the x-axis is age. So how old are you definitely governs how likely are you to die from a virus. These blue lines are the most recent flu seasons that we have data for. And the red lines are the various estimates of the infection fatality rate of SARS-CoV-2 or COVID. And certainly, and remember again, this is on a log scale, certainly when you get up to upper age groups, you're talking about 9 to 15 times higher infection fatality ratio with COVID than with flu. But when you get down here into the kid range, you can see that a bad flu season, like this one here, which was, I think, the 2017-2018 flu season, is worse than COVID. And I think that as we start to consider how to educate our patients and their families and how to make decisions about what our kids can and can't do right now, we need to keep in mind this disease is completely different in pediatrics than in medicine in general. So that brings us to transmission, and I'm just going to cover on a couple of brief topics here. I know you guys know most of these next couple slides, but I want to sort of really bring that point home. Remember that R0 or R0 is the average number of people who will be infected from one infected person. And as devastating as COVID has been, we need to kind of bear in mind that there are different versions of this. One thing that this tells us when we do these comparisons is a little bit more about transmission. So if you look at the R0 of measles, it's 16. Smallpox is 6. These are definitely mostly transmitted by an airborne mechanism. There continues to be this debate about whether COVID is transmitted by airborne or just larger respiratory droplets, because that governs what we're going to do for our safety measures. But the fact of the matter is that the majority of transmissions are through large droplets. So our safety measures like masks and distancing make a major difference, as they wouldn't if this were with measles. And importantly, that R0 is an average. There's massive heterogeneity in COVID transmission. So this is an epidemiology study of some of the early transmission events in this country. And each dot represents a person. The gray arrow is a direction of transmission. So for instance, this person transmitted it to 4 other people. and this one to many more. And so you can see right off the bat that most infections don't go anywhere. In fact, all of these little dots here that don't have an arrow after them, they didn't transmit to anybody at all. So only about 19% of the infections are responsible for 80% of the transmission events. It's very heterogeneous. And 69% of infections are actually not transmitted to anybody. Again, it's a little bit different than measles or even flu. But social gatherings are really driving transmission through these super spreader events. This W here is for a wedding that occurred. This was in a temple, and this one was in a bar. Now, I'm not anti-bar, but right now I guess I am. What I really am is anti-bar behavior, because bars are sort of a setup for everything that there is about transmission of COVID. But we have to bear in mind that when we're talking about blocking transmission, it's these interactions with people that we have to be careful of. And we have to keep reminding people are really tired of this. And if you were just watching the inauguration like I was, there was all this sort of tension about when somebody put their mask on or off as they were stopping to speak. But we do have to keep reminding people that these safety measures we keep preaching really work. So this is a meta-analysis of COVID-19 based studies, just the stuff that's come out since the epidemic started, and the ability of various safety measures to change the risk of infection. And you can see there's a large number of studies involved, and the distancing, face masks, and eye protection all have a substantial decrease in the risk of acquiring an infection. And there's a large absolute effect. If you sort of put this in toto, you can affect a 65 to 85% decrease in transmission just by simple safety measures alone. We all know that, and we all practice that, but for whatever reason, it's really hard to keep this going. And we need to keep being out there and really educating people and reminding people. And that's important because this decreasing social exposures will decrease that R naught. So that for instance, if we could reduce social exposure just by half, one person at day 5 would infect 1.25 people instead of 2.5. And after 30 days, you're talking about 15 people infected. Even less if you could reduce it by 75%, which the data shows us is entirely possible. And this is, of course, why we need to do that, is that exponential spread is exponential. And that if we don't take those measures, we're looking at continued massive spread and transmission. So I wanted to put some of this data out there just to give you some more ammunition, maybe a little more juice in the tank to continue with all of your education efforts. It's hard. It sometimes feels like nobody's listening, but people are listening, and it's very important. The next thing I wanted to talk about in terms of transmission is some of the newer news about viral evolution and variant strains. Viruses evolve. We all know that. There's a new flu every couple of years. That's why we always have to keep getting new flu shots. And obviously, this virus evolved from other viruses, so we know that they evolve. But they evolve at different rates. So what this is a substitution rate. In other words, how many mutations in the genome are fixed per year. And the higher number is more substitutions. And it's based on genome size. And I put blue on these DNA viruses. DNA viruses don't tend to have a lot of mutation, but when they do have mutation, it's in proportion to their genome size. So herpes viruses, which have this massive genome, wouldn't tolerate a lot of mutations per year because everything would fall apart pretty quickly. Whereas something like a BK virus, which has a very tiny genome, can tolerate these massive number of substitutions because that's how it gets its genetic diversity. Viruses aren't out there breeding for the most part, but this is where diversity comes from. And viruses, of course, don't care if 10% of the virus population in your body dies off. It's only another generation before they can make that back up. And if there's a mutation that increases fitness of the virus, which is, of course, decreasing fitness for us, but then the virus wants that evolution effect. The RNA viruses, though, are a little bit different. And here are the coronaviruses here, and SARS-CoV-2 falls in this category. But this paper was actually done in 2017, and I kind of wonder what the people who wrote it feel like now, because they titled it, "Are RNA viruses candidates for the next global pandemic?" A little scary. But the point here is these RNA viruses with these high mutation rates have the ability to cause pandemics in the way that other viruses don't necessarily. So strain surveillance is critical for public health. I think that point's been made in the news lately. Variant strains might spread more quickly, which we've heard a lot about. They could also cause more severe disease. So far, we haven't seen much of that, but it's a worry. There's another big worry, which is that they could evade detection. we'll talk more about that in a minute. But the reason that our PCRs use multiple different genes is so that if something changes, for example, in the spike protein, which happened in the B117 lineage, the new variant from the UK, that we still have 2 other genes in our PCR, so our diagnostic tests are still working. There could be decreased susceptibility to therapy, which would be an issue. Not that we have great therapies yet, but it could happen. And the ability to evade natural or particularly vaccine-induced immunity would be a real problem. So we do need to keep our eyes out on these strains, but we also don't need to panic. And what I want to point out to you is that new variants have already happened. So I don't know why. I guess there was a lot more news about different things because it happened early in the epidemic when we were all still adapting to this sort of new world we were in. But there was a spike protein amino acid substitution at position 614 from D to G that happened in March. And it actually did increase viral load and transmission, but not severity of disease. This is a graph of the world, and the blue is the new strain, and the gold was the old strain. And before March 1st, here's where it was sort of circulating. But by the 3rd week of March, it had become the dominant strain throughout the planet, really. And this is what we're expecting to have happen with the new 117 variant from the UK. So this has already happened once. I just offer this as evidence that this is part of the process of the virus. It doesn't necessarily mean that it's time to panic, but it does mean this is something we always have to be watching for. So this variant that I told you about, most people are now calling it B117. It has lots of other names too. It was first identified in Southeast England in December of 2020. And it has actually a relatively large number of substitutions. It's not just one change, but it has several that are really important. And we do think that it is going to have increased transmissibility, and we expect it to take over as the dominant strain probably by March in this country. There's right now no expected change in disease severity, and specifically no change in expected efficacy of the vaccine, which is great. But well, again, something we need to keep an eye on. The big change is this N501Y change, which has actually happened in several different independent events in the virus. And it's probably what's causing transmission because it sits at the point in the virus where it's binding to the ACE2 protein. There's also a deletion of amino acids 69 and 70, and that's a real issue because that's what's causing what you hear about as PCR problem, is the S gene target failure. So the PCR probe that picks up the RNA for spike protein in our diagnostic PCR test happens to sit right at this position. And when there's a deletion here, the primers for that PCR aren't binding to the viral RNA. So what you get is a negative result for the S gene, even though it's present, because we're just not detecting it. That's okay. We have these 2 other genes in the PCR right now. And actually, it's giving us a marker for following this virus, because when you see very hot hits on the other 2 genes, ORF1A, 1B, and the nucleocapsid genes, but the negative S gene, that's a marker for this new strain. We'll have to see how things go. Things could change in the future. And if we get more dropouts in our PCR, we'll have to modify our PCRs. So that's a little bit about sort of transmission dynamics. You can expect, as long as this outbreak is going on, for these issues about variations, possible diagnostic issues are going to continue to come up. These super spreader events are going to continue to come up, and education continues to play a massive role. So what else can we do other than trying to educate people? Well, there are possible treatments. And we can talk about those a little bit. I'm going to mention this one, and then I'm going to flip through a couple real fast, and you'll see what I think in a minute. So supportive care really is what we've got. It is what works. It is what gets people through. And I'm including in that supportive care dexamethasone and probably anticoagulation. I put probably here. It depends on your patient and their risk. So the very young kids who have very, very, very low risk of coagulation probably don't need anticoagulation, but certainly most adults who are hospitalized with severe disease are having some version, some level of anticoagulation depending on the patient. And again, here's the data for dexamethasone. Y-axis is mortality and the days in the trial. And these are, so if you use usual care, which at the time did not include dexamethasone, the mortality is higher than if you do. I don't have confidence intervals on here, but it was significant for all patients. But really, dexamethasone becomes a big issue when you're talking about people with severe disease. Because by the time somebody ends up on mechanical ventilation from COVID, just like with lots of viruses, it's the host response that gets you. This is why if you're going to treat somebody with Tamiflu for flu, you have to do it in the first 48 hours of symptoms, because the viral replication is those first couple days. And after that, it's the host immune response that causes the rest of the symptoms. And so people with severe disease, like those that are going to need mechanical ventilation, are really going to benefit from just sort of slowly turning that immune response down a bit. This isn't something that you would necessarily want to jump to the day somebody's diagnosed, because that's when they really are producing that important productive immune response, but more later when they're in more severe, more chronic inflammation modes. There's lots of antiviral therapies that we've investigated and tried, a couple I'll mention here in a minute, but they all have really common themes. There's absolutely no data in children for any of them. The lowest age for some of these was at 16 years old, but almost all of the study patients, even in studies that included 16-year-olds, the number of 16, 17, and 18-year-olds was really tiny. So almost all of these are studied in adults, and honestly, most of them were studied in older adults because of the concerns, again, for the different issues with fatality there. And the data that we have is really limited. I don't know if anybody of you had a chance to really look at some of this, but it's very limited, and the effect size and possible overall efficacy is very low. And often, again, because these are targeting the virus, and I just mentioned that's those first few days, just like with flu, you have to give them fairly early in disease to make a difference. And sometimes you get there and sometimes you don't. So our PEDS ID group reviews these regularly, and right now we don't recommend use of any of these in children, with the never say never caveat. I'm sure that there will be a circumstance coming up sooner or later where somebody will call and say, I know you don't think we should do this in kids, but here's the situation. And I'll probably go, oh, yeah, right. But that's going to be one of those sort of complex academic level decisions that we should make together. I do not recommend using these routinely. So here they are. Here's remdesivir. I've got some comments on these things because you have copies of the slides. I'm not going to go into that in the interest of time. But here's remdesivir. So, and this time is the proportion recovered, not mortality. So it's flipped. So blue remdesivir is on top. That shows a remdesivir benefit. But the light blue here is the confidence interval. So anything that's white is where there's a significant difference. You see these little teeny tiny white windows? Significant difference. And this is patients who have somewhat moderate disease with low flow oxygen. Once you hit the point where a patient has severe disease, there's really no difference whatsoever from remdesivir. Same thing with convalescent plasma. This time it's a forest plot. So dots and bars on this side of the line suggest that plasma has a benefit. Those on that side of the line suggest a detriment, and things on the line are neutral. So depending on how you look at which patients you give it to and how you do it, you can find different data from the study, but you'll notice that pretty much everything is sort of hanging pretty close to this line. If you give it earlier, you get almost significant values, and also if you give it to the sort of healthier patients. But again, there's really no great data to suggest that this is useful. There are some more recent studies that suggest in very specific patient populations at very specific early times in disease, it might be useful. But this is what we're looking at in terms of efficacy data. The same thing with the monoclonal antibodies. For unknown reasons, it's easier somehow to say bamlanivimab. So people are saying BAM or bamlanivimab for the Lilly product, but casirivimab and imidevimab are harder to say, and there's two of them, so we usually just call this the Regeneron cocktail. But there's a very flat dose response curve. If you give lots of antibody or a little antibody, there's not much difference. There may be a decrease in hospitalization if it's used early. This is the data on bamlanivimab and its ability to impact viral load. So this is a log of viral load, high when you start therapy and lower after 11 days. But this red line is the placebo, right? The natural immune response for most people will clear these in time. And there's, a significant difference in this clearance of viral load at day 7, just barely. Error bars don't actually overlap, but it's just barely. But I find this one was really interesting because the FDA approved this for use in people who are 12 years old and older. There were no 12 to 17-year-olds in any of these studies, none. And if you look at the emergency use authorization, it specifically says that it's approving it in 12 to 17-year-olds based on expected similarity with adults. Now, if this was going to have a massive effect on disease outcome, and you'll notice I don't have a disease outcome slide here because it doesn't have a massive effect on disease outcome, maybe I would be willing to take that sort of risk and say, okay, there's expected similarity, and I've got this patient for whom I'm desperate. But remember, I don't usually have a kid for whom I'm desperate. Even the kids who are immunocompromised or have severe risk factors, or many risk factors for severe disease, they do pretty well. Even them, right? So if there is an effect here, I think that the ethics of it are that we should give it to sort of the populations, the adults who are in trouble or are likely to be in trouble because it has to be given early. And there's really no reason to be giving this wholesale to kids. Again, never say never, but it's not routinely recommended. And so what else do we have? We've got vaccines. Also not studied in kids, but certainly something that we need to think about. And vaccinating adults actually can be therapeutic for kids too, as we decrease susceptible individuals and increase herd immunity. That's probably the way we're going to get out of this pandemic. So that's the goal, right? The big goals for vaccines are to protect the person that's immunized. That will solve the therapeutic timing problem, right? Because you're actually intervening before they're even infected. So you don't have to go through that, oh, I have to do this really early to have any impact. Ideally, it would also block transmission, which would be great because that would definitely help and spreading, and it will decrease the number of susceptible people in the population. And that number of susceptible people in the population impacts are not as well. Because if half the people are resistant, then, half of the time there's not going to be a transmission when there would be. So these are our goals for vaccines. And many of you have probably seen the movie Trolls. If you haven't, this is the main character, Poppy. She's the hero of the story. And the reason I bring her up is we have this thing in my family about her tagline. And so basically when she's going out into the forest and she has to sort of rescue, like brave the forest and change the behavior of this big person who's eating trolls or something like that. She goes out to the forest and she sings this song, right? She says, I hope I can do it because they're depending on me, blah, blah, blah. And the end of the song is, how hard can that be? And that's a tagline in my family. When somebody is starting to talk crazy talk, one of us will turn to the other and go, how hard can that be? And that's what I feel like this battle that we're fighting with the vaccines. It turns out that although it's a crazy hard, maybe we're getting there. Actually, we are. I shouldn't have any hesitancy. We're definitely making major progress here in a way that I didn't actually expect. But how hard it could be maybe is demonstrated here by the number of different things we're trying to do at the same time. And also, I would point out, I don't know that I've ever given a talk before where I was using the New York Times as a reference fairly often, but they're actually doing a lovely job of collating data. And again, for example purposes, they have a COVID vaccine tracker. This was, late last week when I was finishing up the slides for this talk. And it tells you all the different things that are at the different phases of testing or approval. And it kind of gives you some sense of exactly how hard we're working. So these are big goals, but when we put the force of global science behind it, maybe we can brave the forest and save the people. So one of the problems, there are many, but one of the big ones with this is something called vaccine-associated enhanced respiratory disease, or VAERD. This is where the how hard can that be really kind of comes to the forefront, which is that for SARS, the first SARS, and MERS, people have been studying vaccination and immunity to these because coronavirus immunity is important. And also these were actually pretty high candidates for causing a pandemic. It wasn't completely unexpected. Certainly not predictable, but not a shocker. And so what happened is when you would give these vaccines in animal models and then give them wild-type virus, their disease got worse. And it was probably a Th2 response. And what it brings to mind to everybody was the original trials of formalin inactivated RSV vaccine, which was a long time ago. I'll tell you more about that in a minute. And it happens in non-human primates, which is a big concern because their immune systems are very similar to ours. And it's more prominent in aged mouse models because, aged people are the problem where they have the most severe disease. So there was a massive worry that immunizing people for SARS-CoV-2 would actually just make everything so much worse. And that is actually why when the FDA set out its requirements for what would have to happen for a successful phase 3 trial, they indicated you had to have a minimum number of severe cases in the placebo group. Because if the vaccine was making it worse, you had to have enough cases in the placebo group in order to be able power to detect that worsening. So I don't know if you ever noticed on their documents that you had to have, I think it was 5 cases of severe disease in the placebo group. That was so that if this was happening, we could find it. And the RSV data, which this really does happen, and it is a really big problem when it does, is that in 1968, they had this RSV vaccine. You'll notice that we don't still have an effective RSV vaccine, and the field was really set back decades because of this. What happened was they took infants who were at high risk for severe RSV disease, and they immunized them with the RSV vaccine or also a candidate para-influenza vaccine, and they followed them over the next several years and looked at who had infection with RSV and what happened. So in the RSV vaccine group, 65% of these kids that they were following got RSV infection, and of those who got the infection, 80% were hospitalized. And it's not just because they had a vaccine, because the same thing with the paraflu group, they had just about the same number, same percentage of kids who got actual RSV infection, and 8% of them were hospitalized. So the RSV vaccine actually made a massive worsening in the immune response and thus a huge worsening in disease and caused massive pneumonitis in these babies who ended up getting RSV. So vaccines are not always going to help you. And that's a big worry and a big hurdle that our vaccines crossed recently. Anyway, I think I mentioned that was, it turns out that the mRNA vaccines at least have not had any demonstration that happens. It's not happening with these vaccines, and that's a big relief. It's not something that can be predicted. And like I said, in our animal models of vaccines for SARS-CoV-1 and MERS, that it did happen. So it all depends on which component of the immune system you're stimulating and how can you get a good immune response with the proper sort of Th1 or antibody channels and not the one that's going to cause this massive cytokine response. The good news is it didn't happen with the mRNA vaccines, and so far it's not happening in any of the other vaccine trials. These are basically the current candidates. So you know a lot, I think, about the RNA vaccines. And I apologize. I was pulling the slide deck together. I forgot to update the under review. Obviously, both of these, Pfizer and the Moderna RNA vaccines, are approved. There are a variety of other vaccines that are in pretty far along in phase 3 trials, and so we may actually have choices soon, which we'll have to figure out what best we can do with the best data we've got. So we talked about the 5 patients in the placebo group, so we picked it up. There's no vaccine-associated enhanced respiratory disease that we're seeing right now, which is great. But there's all sorts of other things that can go wrong with a vaccination program. And one of the concerns I hear all the time is, wow, they used 2 months of safety data in the vaccine trials. That can't possibly have been enough. Vaccine takes years to evaluate. And how can 2 months be enough? Well, it turns out it is enough. And that's because when vaccines do go wrong, it usually happens pretty quickly. So like when potato salad goes bad, when vaccines go bad. If there's going to be anaphylaxis, you certainly know about that right away. There is some limited anaphylaxis that occurs, but so far, all of the patients that we've had immediate reactions, no one's had full-blown anaphylaxis here, but it's been described. But it all is effectively handled by standard treatments of anaphylaxis. Several weeks into a vaccination program, you can find errors or problems that are occurring from formulations. The most famous example of this is called the Cutter incident, which was in 1955 when they were first starting to make attenuated live virus polio vaccine. And some of the batches had actual wild type polio virus in there. So we actually, unfortunately, injected wild type polio virus into all the kids that got these vaccine batches. So that was a big, big problem. Obviously, our techniques and our industrial standards and things like that have changed a lot since then. But you can have formulation problems, but they can be detected very quickly. 6 to 8 weeks is where most of the major sort of, wow, that was a funky immune thing we didn't expect to happen happens. So the whole thing with rotavirus vaccine and intussusception, the first rotavirus vaccine, not the one we use now, was associated with increased risk of intussusception, which seemed to be an inflammation in the Peyer's patches causing lead points. That happened within 6 to 8 weeks of immunization. Similar Guillain-Barré syndrome, when that's happening in response to vaccine, it happens in that first 2 months. So that's where that 2-month safety window came from. And those are really the major vaccine problems. Well, what about the VAERD and the other stuff? And what about measles and all that? So there are these other problems that can occur when an immune response is going to be too vigorous or too atypical because of the vaccine. If that is going to make the disease worse, that usually takes a while to detect. I showed you that RSV study took 2 years, right? The issue there was you usually have to wait a while for the person who was immunized to be exposed to the infection. I'm not going to say this was lucky because this pandemic has nothing that's fortunate about it, maybe. But because there is currently such a high level of circulation of virus, you didn't have to wait years to see what would happen when an immunized person developed infection. We had lots of cases, we'll show you some of that data in a minute, of people who were immunized who got infection. And so this was actually something that could easily be evaluated in that 2-month window, whereas normally that would take years. And then finally, there are these proposed late adverse events, but so far they've all been debunked. I can't even say MMR and that a theoretical problem that happens in the same sentence. I can, but I don't like to. But obviously, we know that MMR does not cause autism, and now that's actually documented intentional fraud. But there are things, there were associations that were much more innocent than that, like the initial observation that hepatitis B vaccines seem to be associated with multiple sclerosis, or that the H1N1 flu vaccine seem to be associated with narcolepsy. And after lots of intense research, it's clear that those were sort of associations or clustering effects and not actually causative. So far, all of the late events that have been proposed as adverse events from vaccines have been debunked. I can't promise you that there will never be some sudden late immune issue found with these vaccines, but the fact of the matter is that the overwhelming majority of vaccine adverse events happen in these first 2 months. And so 2 months of safety data really is enough. And then the other question that I get a lot is, well, but they're mRNA vaccines, and we don't have any idea what an mRNA vaccine would do in terms of adverse events. So you can't make that analogy of 2 months being enough. Well, mRNA vaccines are not actually new. These 2 vaccines are certainly the first ones that are given to millions of people, but we've actually been working on mRNA vaccines for quite a long time now. They were first given to animals in, I think it was like 2008 or 2009, and the first human trials with mRNA vaccines were in 2011. So we actually have pushing on 10 years now of data on the use of mRNA vaccines. And if you look at clinicaltrials.gov, and this was in December, last time I looked, there was a total of 91 different studies that were going on for mRNA vaccines, 4 of which were in active, large-scale phase 3 trials, and 7 of those trials include children too. So that's good to hear. And this is actually a little piece of data from a relatively recent review of mRNA vaccine trials. How come none of them have been approved yet? Well, as you know, the normal approval process is quite slow, and some of these targets like HIV and rabies are very difficult targets to tackle with vaccines for a variety of unrelated reasons. But there's lots of mRNA vaccines that have been used in people with very nice, successful correlates of immunity. They can demonstrate antibody and T-cell responses. So they're not new. It feels new because it's the first time we're really hearing about them being used, but they're not actually new. And this is how they work. I think you probably know this, but just in case to put us all in the same part, there is, it says vaccine particles. What it is it's RNA coated in some lipid micelles. What that does is it protects the RNA until it can get into the cell. Also, the lipid micelle facilitates movement of the RNA across the cell membrane. And once there's RNA in the cytoplasm, and this is mRNA, and it's labeled as such when it's made, it hooks up with a ribosome and starts making protein. That's all it really is. We're just putting mRNA into cells. They're making spike protein. Sometimes those are degraded. Sometimes they're put into the membrane intact. So you get both exposure of the immune system to intact spike protein on the surface of an object, as well as displaying spike protein fragments via the MHC system. The mRNA never goes into the nucleus. So we have major defenses in our cells against that happening. So that's good. they're fast and easy to produce. Well, not easy, but they're fast to create and they're not hard to produce. And mRNA itself, any single-stranded RNA really is what happens in viruses, not people. That would be outside the cell, of course. And so it's a danger signal. So not only do you get this sort of rapid development of the protein in the person, so you're not dealing with all the problems that happen with producing safe proteins in vitro. It's easier and safer to produce mRNA in vitro than proteins. So you produce the protein in the person. But not only that, but the RNA that doesn't get into the cell that's still out here is recognized by the immune system as a danger signal because it's telling the immune system that there's a virus in the neighborhood. So you get actually an antiviral type immune response to spike protein, which, biologically is exactly what you want. Because RNA cannot get in, mRNA specifically cannot get into the nucleus, and because it's RNA and not DNA, you're not going to get insertion into the genome, so you're not going to get mutagenesis there. You're not going to have live virus vaccine reverting, so you're not going to have like the atypical polio virus that we see now with live polio vaccines. And not only that, but the mRNA doesn't go anywhere. It is rapidly degraded. Naked mRNA, if you mix plasma and mRNA in a tube, the mRNA lasts about 15 seconds. Literally. I don't have the study data here for you, but it literally lasts 15 seconds. By the end of 15 seconds of mixing plasma and naked RNA, you can detect less than 1% of what you put in there. So once this is outside of a cell for one reason or another, it's not going anywhere. It's just going to be degraded immediately. So that's why you have to have these sort of lipid particles actually to protect it long enough to get it into the cell. But even within a cell, mRNA turnover is pretty fast. So within about 2 to 3 days, you cannot find any of the mRNA from the vaccine anywhere in the body. So this is actually a not bad strategy if you think about the biology behind the immune response and things that you would want as far as safety. It's not great, again, because we don't have decades of data based on this strategy, but we do have actually a decade. So we'll have to remember that. It's also not great because they're pretty unstable. People have been working on that. Moderna has gotten its vaccine to the point where it can be stored in a regular freezer, which definitely helps. So here's the data behind these. The BNT162b2 is the Pfizer product. mRNA 1273 is the Moderna product. These are the major efficacy graphs from the two studies. Both of them have a cumulative incident or event rate on the y-axis. So this is the percentage of people in the trial who got infected with COVID, or got infected with SARS-CoV-2. So here's the placebo. Over time, there is a rise in the number of cases. That's not a surprise. That's the pandemic. We know that. But if you give vaccine, either one of them, and watch over time, there is a massive decrease, 95 to 98% decrease in the number of people who are have detectable infection. This is what you really want. We don't know yet if it's causing, if it's blocking disease, because these were detected by symptoms, not by regular testing. So these are symptoms of infection. We don't know if it's blocking actual infection or if the people are being infected but not developing disease. But we will know that soon. And people talk a lot then about some of the side effects and other issues and what was the study about. You can see we're already at, by the time these trials were done, at tens of thousands of people had received these vaccines. That rotavirus vaccine study that ended up with an interception, when they made a new rotavirus vaccine, the FDA required that there be 30 to 40,000 participants who received vaccine in order to sort of screen for that effect. So we're right up there in those numbers of massively large trials to get as much safety data as possible. They did include a lot of people who are over 65 because those are the people that we really need to protect from the disease. And they did their best to include sort of a diverse group of people, given the difficulties of more severe disease in people who are non-white. Reactogenicity is something you hear about a ton. So I wanted to just compare these. All the time, people will come up and say, well, I heard the Moderna vaccine is less reactive, or I heard this, whatever. Reactogenicity is a short-term side effect, usually 24 to 72 hours after you get the vaccine. And they are symptoms of the immune response. Anytime you turn that particular type of immune response on that way, you're going to get those symptoms. It's not an adverse event. It's a side effect. So I pulled just because they were in the studies the same way, so they were comparable, the data on pain and fatigue. There's lots of different descriptions, but I'm going to use these as markers for our discussion. And so for both of these, if you compare the numbers in the sort of placebo column versus the vaccine column, and over here for the Moderna vaccine, you can see obviously there's lots more in the vaccine column. Not a surprise because there's something to react to. And then what I put here, this first one / second one, this is the first dose, after the first dose, and after the second dose. So there's a significant amount of fatigue after placebo. So human beings, what they are, they all have a fair amount of fatigue, but it increases a fair bit with vaccine. And for all of these different sort of side effects, the second dose is worse than the first. You could look through these studies and pick out, well, the Moderna one clearly hurts more than the Pfizer one. That's probably because the Moderna one's in 0.5 mils and the Pfizer's one's 0.3 mils. So there's more volume in your muscle to give you more pain. I don't know, maybe. Or you can kind of say, well, this one's less fatigue than this one or more fatigue than that one. But when you combine all this reactogenicity together, they're pretty much spot on the same. You get the same amount of reactogenicity. It's actually a little bit reassuring because they're both different ways to put the same mRNA into the cell and produce the same spike protein. They're both mRNA for spike protein. So the fact that their reactogenicity and other side effects are very similar is biologically reassuring because you're looking at the same immune response. And here's the efficacy data, right? These are the cases of symptomatic COVID-19, dramatic decrease. And there was no vaccine-associated enhanced respiratory disease. And the storage conditions you know about, the days between dosages is another difference. And then down here is a map for where the vaccine is currently approved. Yellow is emergency use approval. Green is actual official full approval. And over time, the number of places in the globe that are turning yellow is increasing slowly. But they're both now being widely used. And I think we're up to, 12 million doses given in this country. So that's the RNA vaccines. They're here. They're being given. Many of you have probably gotten one or maybe already two. If you haven't, you should look into sort of how you can, because by nature of being part of this Grand Rounds group, you are in phase 1A as healthcare providers. What else is coming down the road? Well, the other big set of vaccines that's coming quickly up is adenoviral vaccines. Remember, I said with the mRNA vaccines that there was a lipid particle that protected the mRNA long enough to get it into the cell and to facilitate crossing the membrane. So the mRNA, and here's the same thing, it's spike protein mRNA. That's going to be the same no matter what. And then, this isn't mRNA. So these are mostly DNA encoding because it's loaded into adenovirus. I take it back. There's another one that delivers mRNA. I'm not talking about today. But this uses an adenovirus capsule or shell. There's no adenoviral DNA in here at all. The only DNA in here is the DNA for spike protein. The virus, though, has the receptors, and it engages the appropriate receptors and induces its own uptake in the cell. So that's an efficient way to get it into the cell. But with these vaccines, they're DNA vaccines. Then the DNA is translocated into the nucleus because there's a system in our cells that says DNA in the cytoplasm, that's a bad idea. It's supposed to be in the nucleus. Stick it back in there. So it takes it in there all on its own. And then the DNA in the nucleus is translated into mRNA, which then goes out into the cytoplasm and a spike protein is made, and then the same things happen. The DNA in these vaccines is very, very specially treated to block the ability of that DNA to integrate into the genomic DNA. I don't have data on how effective that blockade is, but we have lots and lots of data on adenoviral delivery systems of DNA. And we're getting pretty good at dictating which DNA should be integrated and which shouldn't. So then there are different adenoviruses that are being used with the different vaccines. They're here. One to be paying attention to, CanSino Bio's Ad5 vector, is adenovirus 5. This is human adenovirus 5, which a lot of us have already had. So we have an existing immune response to adenovirus 5, and it looks like this may be somewhat less efficacious, and that may be because we're clearing it before we're actually delivering it to the cells. That's all at this point conjecture. I'll let you know next year or the year after, but you'll have already heard in the New York Times whether or not that turned out to be true. But the AstraZeneca vaccine is already being used in the UK. J&J's phase 3 results are due out any day now. And the CanSino Bio adenoviral vector vaccine is actually already being used in the Chinese military. So here's the AstraZeneca data from the one that's already being used in the UK. This was the one that had this low dose, high dose thing. So what happened was, it's not really cool to think about this, but a bunch of the participants in some of the original trials were accidentally given less vaccine than they were supposed to be given. So everybody's supposed to get the standard dose, but some of the people in some of these original trials accidentally got a low dose for their first dose. And it turns out that when you do this low dose for the first dose, the efficacy is higher. Science works this way. It is a series of random accidents that somebody was paying attention to. None of us like the idea that the study happened in such a way that that kind of error was made. And I don't know the details about how that occurred. It could have been, it almost certainly was completely innocent, but people were paying attention enough at least to realize that it happened. And then somebody else paid enough attention to realize it was a fortuitous accident. Because if you look here at vaccine efficacy, when they have the low dose first and then the standard dose, the efficacy is 90% compared to about 60% when you got 2 standard doses. So we'll probably learn more about that as we go along. It actually helps a little bit because since you don't have to make as much, you can actually make more numbers of vaccines for people. It helps a little bit less in terms of logistics because you have to make sure people get the right doses on the right days. Regardless, there definitely is strong efficacy. So this was the study data for all recipients. And again, this is the this is the control. So this is the number of events in terms of the number of infections. They gave people a meningitis vaccine as a control so that the random generic immune response would be included in the study. And there was, as usual, a predictive linear increase in the number of people who got COVID in the placebo group, and then a substantial protection in the vaccine group. So, like I said, this one's already been approved in the UK, and it's under review here. One of the things that came up with this trial is this was one of the trials where the trial was paused in the US because of a possible complication that turned out not to be a complication. So the US data is a little bit behind, but I wouldn't be surprised to hear more about this soon. Finally, there are a couple of other sort of unique strategies. The Novavax vaccine, that's the data, should also be coming out soon. But they were started a little bit later than some of the other studies, where they actually do manufacture the spike protein in vitro. Then they assemble it using nanoparticles and an adjuvant into these sort of nanotubes that are expressing spike protein. So they look like a virus that's expressing spike protein. And that's sort of like human papillomavirus virus. So those are those virus-like particles. The immune response responds much better to assembled virus with spike proteins, or in this case, assembled nanoparticle with spike proteins, than it does to the protein by itself. So that's the techniques there. And the early, the 1-2 trials showed extremely high antibody levels after immunization with this particular vaccine. So again, the studies are a bit behind the other ones, but it has good promise. So that's sort of treatments and vaccines, a very, very quick overview. And just a few more slides. I know we're running short on time. I just want to emphasize a few things that you can do and some data I want you to be sure you have. What can you do? Educate, educate, educate. I don't know if you're a Yoda follower or not, but fear is the path to the dark side for sure. Education can help people really understand what's going on. They can understand why they need to wear their masks, etc. Test. The only way to know if somebody's got COVID and not some other respiratory virus or some other symptom is to test. I know that testing turnaround time can be a problem and test availability can be a problem. And so there sort of diminishes excitement about testing when you're not going to know the answer for 5 days. But even if they have a long turnaround time, it still enables contact tracing. So really keep testing people. And there's no way to know. Kids present with a single symptom. Right, so 16, maybe even as much as, as 45%, depending on the study, of children who present with COVID have no symptoms whatsoever. So you're not going to catch them, but 48% of them present with fever. So half of them don't have fever, and there are a bunch of very non-specific symptoms that kids present with. Not only that, but often they present with a single symptom. So in these systematic review, a meta-analysis of pediatric presentations with COVID, 44% of them presented with a single symptom. Fever alone, cough alone, diarrhea alone. Right? In no other circumstance would we test anybody for any viral illness if they presented with diarrhea. in general. For specific patients, yes, but not for everybody. But we should be testing all of these kids because it is so subtle when it presents in kids. So test, test, test. The only way you can know is to test. And then I'm going to skip some of these, but just the last couple little pieces of information as far as education goes. Remember, I showed you that curve where the flu and the COVID, and the younger you were, the more likely flu was to be a problem and COVID was less likely to be a problem. I struggle with ways to present that to patients and their families, but this group actually from Europe came up with this, which is if you look at the age group of 0 to 34-year-olds even, and 34-year-olds, you're talking about people who can get pretty severe COVID. Of those who get COVID, you're talking about 0.004% of them will die. I don't want to minimize that. Anybody dying is bad. However, if you look then at that same group of people and how many of them die in an automobile accident each year or another accidental death, they're actually more likely to die in an automobile accident than from COVID. And I bring this up because this is something that you can educate your patients about. It's a piece of real information that we can give them. In the US, a child in school is more likely to die from a school shooting than from COVID. These are pieces of real solid information that we can give our families to reassure them. When we think about COVID in school, we don't need to be worried about the kids. We need to be worried about the teachers. And this is that last piece of information I'll show you, which is a recent CDC report from the public health group in Mississippi. And what they did was they took all of the kids during a certain period of time who had a positive test. And then of the kids whose test result was negative, so everybody had a test, but of the kids whose test result was negative, they cohort matched them with the kids who had positive tests. And then they looked at risk factors to say what is going to predict a positive result, right? So again, a forest plot. So here on the right-hand side is increased risk of positive test. The left is decreased risk of positive test, right? So increased chances of a negative test. And as you might expect, visitors in the home, significantly more likely to be a positive result. Same thing with social gatherings and children's birthday parties, right? But school, if you look in the 14 days before the test was done, had the child been in-person school or childcare at all in 14 days. And the average result was that they were less likely to have a positive test. The error bars cross the 1, so it's not significant, but it was less likely. And if you say, were they in school at all in the past 14 days when everybody over 2 was wearing a mask? I take it back. When the student had a mask on, was over 2, and when all the staff members were masked, so you don't even worry about the other kids, there was significantly less likely to have a positive test. So in other words, the kids at school, when they're wearing their masks at school, are safer than they are when they're at home. Again, this is the kind of thing that we can offer our families and educate people. When we think about COVID in schools, we need to be focused on protecting the teachers. So I'm going to leave it there. This is sort of my effort to say there's a gap here, but we do have to jump over it. And sometimes, I think we just need to not look down. We need to focus on where we're going, what we do know, what we can do. And I'm going to leave it there and see what questions people have. And just a reminder, I can't see the question screen for unknown reasons, but we got it tested out ahead of time and I can see the chat screen. So if you want to send something in the chat screen, just feel free to let me know. And I'm happy to take any questions.
We do have one question. It is, does less systemic reactogenicity suggest lower antibody response?
We don't have great big data on that yet, but the anecdotal data says no. So the anecdotal data suggests that and you can kind of get this, right? Everybody's got their favorite. Most genders say that the other gender has man flu or woman flu. I'm not going to try and say who has it, but we all have different perceptions of our symptoms, and these are symptom reports. So it doesn't seem to be specifically related to is it effective or not. So you can have very high antibody or T helper responses and have minimal reactogenicity or vice versa. So I think most of it is how you perceive the the symptoms from your immune response. The virtual presentations are not the easiest version for questions. I'm available anytime. My email address is the standard Iowa one. I think that you guys have it, and you should feel free to distribute it, or just type Melanie Wellington UIHC into Google and I'll pop right up. And feel free always to email or call. I didn't cover much in terms of what we're going to do about treating kids. I didn't cover anything about MIS-C and how we're treating that. We're working on developing protocols now for both of those, but basically kids who do get disease from COVID and kids who get MIS-C need a very individualized approach. And for MIS-C, they need a very specific multi-specialty care. So we encourage you to, anytime you're worried about how to take care of one of these kids, go ahead and call us. It may be that we need to have enough specialties that you may need to send them here or to blank. But we're always happy to sort of talk you through the options on the phone. And we want to be there for you because this is something that fortunately is not happening enough in kids. That we don't all have experience with the severe disease. And I'm totally fine with that. I'd much rather take your calls all day long every day than have a ton of sick kids.
Okay, we have one more question. What about the rise in MIS-C cases and the unknown long-term effects on children?
Yep. So there's been a big rise in MIS-C cases lately. And if you do the math, MIS-C usually pops up 4 to 6 weeks after infection. And if you look at the spike was in late November and early December, and we're right now about 6 weeks out after that. So I'm hoping that we'll start to see a drop. I don't know. But if it's just because we're seeing more cases now because we saw more COVID before, then we should start to see a decrease. We shall see. And long-term consequences of any viral illness are a problem. So all viruses can have long-term consequences in terms of cardiac function, long-term consequences in terms of cognitive function, and a variety of other sort of long-term post-viral syndrome recovery. We see kids, many teenagers in our PEDS-ID clinic all the time who have sort of post-mono and then never get better. That happens with almost every virus. We don't have enough data yet to know how much it's going to happen in kids after COVID. We have seen very, very, very little of this sort of brain fog or cognitive function decline that we see in adults. And the adults in whom we see it are usually adults who've had more severe disease. And it's hard to parse out how much of that is I was an adult being cared for in the ICU for 2 weeks versus cognitive function change versus I was an adult with COVID in the ICU for 2 weeks. That's all still in the works. And for kids, it's even less clear because there's so much less disease. But there are real long-term consequences, and we don't know yet if any of them are going to be worse than from some other virus. But it's one of those things, we just don't have any data yet to sort of tell you what it's going to look like. Long-term consequences of MIS-C tend to be very similar to the long-term consequences of Kawasaki or cytokine storm.
That's the last question I see.
Okay. Well, please feel free to let me know whatever else I can do to help out, and hang in there, keep educating people. And, you know, as we get farther and farther down the vaccine road, hopefully we'll get this much more under control.
Thank you for speaking today. Much appreciated.
Stay well, everybody.